I think nursing is a very exciting discipline, profession, particularly after COVID. And also during the years, we also walk through history. So I hope in the coming 30 minutes, I'll use advanced nursing practice development as a kind of showcase how we go through the journey. So this is the outline that I'm going to talk about. It's very interesting that we have done nursing evolvement in the last, I would say, over half a century. So let me just go through some of the definitions that people are very aware of, particularly our International Council for Nursing, which is the largest association in the world representing nurses. If you look at the definition in 1950, there is a definition. If you have a quick browse, it's focusing on activities that nurses would need to support for patients who are particularly who need to gain independence. Now, after over half a century, in 2002, there was a new definition that came up. If we look at the definition in year 2002, the ICN definition actually has changed the landscape of nursing from the activity-based to actually attending more ecosystem, I would say, the looking at the environment, and also becoming a more professional discipline with support of research and also the attention of the systems more than just the individual patients. Now, I think that a very late document that came up in 2025, I don't know whether anyone had a chance to look at the ICN document. It has even a more drastic change in some way. First of all, the ICN document provided a definition of nursing. If you look at this definition, it's even charging the nurses for a wider responsibility in providing equitable access, safe and sustainable environment to drive health, and also maintaining being a science-based discipline, as well as providing the therapeutic relationships that is the very core of nursing. But then at the same time, it encompasses the development of healthcare, including not only disease, but also promoting health and also maintaining safety and continuity in care. And the interesting part of this document is that it separates the definition of nursing from nurses. So they gave a definition of a nurse, and it specifically mentioned that a nurse is a regulated profession with standards and ethical codes, and it attends to people's health, of course, but it also would attend to the environment and also the public and population health, and also have impacts or have efforts to shape the policy. Now, if you look at the right-hand side, we're working in a world with shared values, but then we would need to recognize that we do have different contexts where we practice nursing. So on the right-hand side, it does say a nurse's scope of practice is defined by the level of education, experience, competency, professional standards, and lawful authority. So the key role is for coordination, supervision, and delegation to others. So I guess this statement actually would recognize a professional nurse would practice with a team, maybe some helpers or supporting the fulfillment of the role. Now, when we move on to advanced nursing practice, we need to recognize that the APN, advanced practice nurse, is actually a professional nurse to start with, but with more education and more experience, then there will be a different scope of practice. So bearing that in mind, I think we need to recognize there is some differentiation that some people may have some confusion. For example, we have nurses who graduate and practice in the healthcare setting. And very likely they will start as a general nurse. And as they go through the career pathway, they will specialize in certain areas. But that doesn't mean that they are APN, just being specialized in that area. But then when they go on with more education and also more preparation, then they will become an APN. So you may ask, what do I mean by saying this? Let me give you the definition provided by ICN again. ICN is a global organization, so they usually come up with the documents with representatives from nurses around the world. So this definition says that APN would be someone, a nurse who has acquired additional education, expert knowledge base, complex decision making, and the competencies needed for the expanded part of the nursing practice. And that definition would depend on the context where they practice. So what do I mean by that? I guess I'll give you some examples later on in terms of the sort of context where we would practice that would make us different maybe from place to place. But nevertheless, I think the commonality here is that I think we would drive nursing to advanced level where we can serve the patients better, particularly with the longevity. A lot of diseases will stay with the particular individual, but they need expert help along their health journey. Now, when I mention branding nursing, I guess we would be looked at what kind of value are we offering we can deliver for our services. Now, this journal article just published last year, 2025, mentions 7 key domains. Number 1 is leadership, providing or enhancing a high-value culture, demonstrating the leadership of nursing in that particular environment. And also we make use of our data, make use of our client information to provide quality and analytics. And interestingly, they also focus on our skills or competence in helping the patient navigate through the system, healthcare system, such as the care coordination. Particularly, the clients may go back to the community, so the coordination between primary and specialty care across care continuum is a way that we could demonstrate our particular skills in nursing. Collaboration and community connections. And also on the right-hand side, you can see that we are also expected, or we can also demonstrate our value in terms of finance and also care redesign and the IT infrastructure in interoperability. Now, with the last 3 points, I will give you some examples in a minute. Now, the 7 domains actually would be very elaborative, but if I can capture it in a nutshell. So this is a simpler diagram that we have developed from a study when we examined the nurse consultant practice. Now, the 3 domains or the 3 strands that you could see is the value or the impacts we have with APN is that we have the kind of impacts on clients. If you look at the right-hand side, I borrowed the competence statement from the Hong Kong Academy of Nursing that would refer to, for the clients, we would be able to manage complex health conditions, enhance therapeutic nurse-client relationship. And in the middle, the service strands is really the attending the system where we would demonstrate leadership and teamwork. And on the right-hand side, we would enhance the professional attributes of not only ourselves, but also our colleagues, and also the discipline. Now, as I said, I will give you some examples of some of the values. Here is the first example, and how we enhance access to care. Now, nurse clinics is one of the care format that would demonstrate APN. When I conducted study on nurse clinics, I often got a question, especially at the beginning. What would the nurses do in a nurse clinic? People are more familiar with what doctors do in doctor clinics. Now, that was a very good question. And when we first started the study that was in Hong Kong, when I did that, that was 20 years ago. And we had to make a framework explaining that actually nurse clinic would help the patient in using the nursing competence, such as health promotion, such as the symptom management, complication prevention. Now, today I don't have time to explain the details, but if you're interested, actually you can go back to this particular journal article and you would have some details explanation. So let me give you a quick example illustration how nurse clinic can help to enhance access to care. Now, we don't claim our value by saying that we can do certain things. I think this document illustrates how the policymakers or the high-level management would expect nurses could contribute to healthcare services. In Hong Kong, we have the largest public system called Hospital Authority that provides care to, in general, 7 million people. So in that particular document, it was stated that they would expect that the nurse clinics would shorten the waiting time and provide care at the right time to the right people. And that is, in short, called access to care. When the nurse clinics were developed, that was quite a number of years ago, and it went through quite a bit of development over the journey, including developing the guideline and also having some accreditation exercise. Now today, actually, this is very well accepted in the system. For example, at the start, when the nurse clinic service was provided, there was no charge. People don't need to pay. But today, this is a formal type of service that people need to register for the service and pay for the service. And also, this is integrated in the journal, in the journey, the patient journey, where the patient would have consultation from the nurse and the doctor and the nurse. Now, this particular service would be very helpful for the low risk, high volume cases. And this is integrated in the patient journey in the hospital authority system. These are some pictures and examples. It happens to be from the oncology nurses. And if you could look at the services, actually they provide services from the start when the cancer diagnosis was identified, and then going through the treatment, for example, chemotherapy or radiotherapy, and then post-treatment, they will also monitor the condition of the patients. So this is an illustration of how the APN can support the patient throughout the journey. And these two photos just quickly show you that there was a accreditation. That means there was a very structured and also formalized care description. So it is safe and it is very helpful. The patients welcome the services. And I think that would be a very good illustration on the value of the APN in delivering this service. Now, this is in the hospital setting and even in the community. I think this is as useful with the nurse clinic. And a number of years ago, I think with our professional group also suggested and also advocate and also actually try to convince the policymaker that nurse clinic in the community, particularly with the health social partnership, this is very helpful. Now, over the years' efforts, finally, last year, in we have a new commission called Primary Healthcare Commission. And in a statement issued by that commission, it was very clearly stated that the nurse clinic was expected to perform assessment, treatment, prevention services, and to support the patient for healthy lifestyle in the community to drive primary health care. The reason I show you all these documents is that we need to get to the policy level so that the practice can be formalized and it can be recognized. Now, the second illustration I like to demonstrate the APM value is the continuity of care in terms of effectiveness and cost effectiveness. This is a study that was done over 20 years ago, but I still like to share this with you because it gave us a very important foundation as we develop transitional care and also health social partnership. Now, if we look at this diagram, I'm sure wherever you come from, I talked to different colleagues from different parts of the world. I read the literature. Hospital readmission is a big issue. That means somehow the patients would go home and within a very short time, they come back to the hospital again. So these are two examples here in our study. One is Mr. Yun. He was discharged with DM, CV, and epilepsy. And then within 28 days, in this particular study, we define remission as within 28 days, they come back to the hospital. And Mr. Yun came back with hypoglycemia. And the second example is Madam Tam. She was discharged with DM, Parkinson, and fall, and came back again very shortly within 28 days with dizziness. Now, if you look at the diagnosis for the two admissions, there is somehow some connection, right? So a question posed by our team was, is there something we can do in transitional care to reduce remission? So we have designed a 28-day transitional care program. Now, in this program, we also took reference of the evidence that if remission has to happen, it would happen within 10 days, at the highest percentage. So we deliver intervention within the 7 days when patients were discharged home, and then we had a continuity of follow-up within the 28 days. Now, as I mentioned, we use a health social partnership. We found out the patient was well taken care of in the hospital in terms of health, but when they go home, they face a lot of challenges in the social context. Simple things like if a diabetic patient, maybe they cannot have the right kind of food to control their diabetes, or they would have problem with medication adherence and all those. So we worked with an NGO to provide shared care, the nurse and the social worker and the volunteers. And it's a randomized control trial. So we developed very set protocol to guide us in terms of the training for the providers, intervention programs, and also the referral pathways. And these are the services that we provided. Now, what happened with the results? Let me show you. There was a great reduction of remission by 60.8% for 28 days. And even at the completion of the intervention at 28 days, we were able to have the sustained effect with 58.9% of hospital readmission reduction within the 3 months. Now, as I mentioned, we would like to also demonstrate the cost effectiveness, whether we have saved money. Assuming each hospital would cost $5,000, so any extra day would cost $5,000, and our average hospital stay for each admission is about 5 days, so that's $25,000. That's quite a bit of money if we're admitting over 1 million patients a year. So if you look at this cost cost effectiveness plane, let me just give you a little bit of explanation. Whatever we do, we want to do no harm. So we don't want to see anything on your left-hand side, which is effect. We do no harm. But then, of course, we want to save money. So if you look at the cost, we want the section under here, below the horizontal line, the x-axis. So that means if we can identify more dots in terms of the analysis on your right-hand quadrant, that will be the best result. So let me show you what we have found. For the 28 days, we have done no harm, which is good news. And we have money saving. But on the right-hand side, for the 3 months, the saving is even better. And we have drawn the curve called cost effectiveness acceptability curve. And there was 89% of cost saving. So this particular study, as I mentioned, is very important for us. So it has reassured that the transitional care with the preparation of the nurse to practice independently in the community, supporting the patient, is very helpful. And also it drives us to do our further work on health social partnership. If you're interested, you can read up on our publications. And now I'd like to share with you a more current study, which particularly this time, day and age, we cannot do without technology. And technology actually helps us a lot. And if you still remember the remission intervention program, we have telephone follow-up, we have a home visit that actually would save, would cost money. In our calculation of cost effectiveness, we took account of into that too. But with technology, we actually can save the transportation time and also the face-to-face time. So this is a program we have developed together with a communication company where they will support us to develop a mobile apps, mHealth. But then we have a question for ourselves. Now, if the technology works so well, do we still need a nurse? Therefore, we have set up the study asking this question with 3 arms. Now, first of all, let me show you what we have in this particular mHealth. We have the self-management portal, health information, but then we also have an alert system in case the client needs further assistance. And also, if there is a need to contact the nurse, then the nurse would have interaction with the client. Otherwise, we would expect the patient or the client would be able to manage with the system supply with information. Now, this is our setup. We asked ourselves, would mHealth provide good results? But then we would also like to know, what if we have a nurse included in there? Would that enhance the result? So that is called mHealth with nurse interactivity. And then we have the control group, which is no intervention, but then they receive the normal services. It's a 3-month program. So let me share with you the results. Actually, the nurse follow-up, the referrals seems to be very, very similar, and the daily use is quite similar. But then if you look at the use of mHealth, it's quite a different with Group A. Group A is the one with nurse interactivity. It has a higher percentage than just asking the client to use the mHealth device themselves. But most importantly, there was actually better outcomes in terms of the quality of life, self-efficacy, and also the reduction of the depression score, use of health services, the systolic blood pressure, and the pain score. Again, if you're interested, you can read up with the publications here. Now, just now, I gave you the 3 examples. of the APN value in terms of how to enhance the access of care, how to provide the care with technology, support with the technology. And then we also demonstrated to you the cost-saving component. And for APN development, I like to spend some time to discuss with you. In the ICN document, actually, it was a document that contained the development of different places. And in Hong Kong, I have assisted writing something what happened in Hong Kong, particularly with the development of the Hong Kong Academy of Nursing. And also we have a nursing council, which is the regulator that has a scheme, which I'll show you later. But there is a very important development there is a career pathway for our clinical nurses. Now, previously, when we did not have the clinical pathway for nurses, nurses who would like to be promoted or do something more, usually they go to management or education. So we lose the best nurses. We move the best nurses away from the patients. But now, with the career ladder, it is very clear in the hospital authority in Hong Kong that colleagues who would like to advance through management, they will have opportunities moving up from ward manager to departmental managers. But for colleagues who are interested in clinical, there was a pathway to keep them to serve the patient from APN to associate nurse consultant to nurse consultant. I don't know whether you are aware, there was a doctor strike, 18 months in 2024 to 2025. Now, that was a long strike, 18 months. And during that strike, services were suspended. So the Korean government started mobilizing the nurses to do more. And that more means giving the position of the advanced practice nurses in Korea to be recognized. So if you could see the photo here, which I got it from the media, that the nurses were very happy with this opportunity. And they mentioned they have campaigned for 19 years for this. And now they have the opportunity with the parliament actually passing some of the rights to do things that they are qualified and trained for. I guess opportunity comes to those who are prepared. So how can we prepare ourselves? So my last part of presentation, I'd like to discuss this question with you. This is a triangle. I call it an iron triangle. An iron triangle means if we lose any single part, we would have the whole triangle collapsed. Every single part is important, including the need for services. And we do need to prepare our nurses to be able to meet the needs of the services and also supported by research. And don't forget, we need policy and regulation to strengthen the whole triangle. I put this in a diagram in a published article, and this diagram actually capture what I mentioned. We need to have service needs, but at the same time, we need to demonstrate the value in the services in supporting the patient and also contributing to the healthcare system. So on the right-hand side, you could see that the impacts, if you still remember the cube I showed you, the impacts can be on the patients, and it could be on the service, the system, and also the profession. Now, if I can translate them into outcomes, particularly if colleagues are doing research, I will recommend 5 nurse-sensitive outcomes that you could consider in your study to demonstrate the value. The first one is clinical outcomes. That's very straightforward, how we could control the symptom, support the patient in improving their clinical conditions. The second outcome is psychosocial outcomes, which very often will be related to health condition. For example, clients who are more the self-efficacy is higher, the self-management is better, or for hypertension, if they can control their stress, the hypertension can be better controlled. The third outcome is functional outcome. The fourth one is physical. Physical meaning money, meaning finance. We can also help to save money for the system. For example, if we can reduce unnecessary readmission, so that would actually save money for the system. And the final one is satisfaction. And they are not they mutually exclusive. In our study, if we can use all 5 outcomes, that would be even better. Now, the other 2 sides of the triangle is education and research and also the regulation. I put it together because I think we need to have competence, and this competence would need to be achieved or attained through education, but then it also needs to be recognized properly through regulation so that our nurses at the level well prepared can practice in a legalized and also recognized way. So I quoted ICN as well as my colleague in McMaster University, Brian Lukosis, and we have published and agree with the ICN saying that formal recognition with regulation actually can standardize APN practice. And without regulation, it can be, the standard can vary, and also we can put the patients at risk. And also one important thing is that we can retain the nurse talents. And if we don't have regulation, I think the nurse retention, particularly the talented nurses, can be diminished. I mentioned that in Hong Kong, we have a regulator called Nursing Council of Hong Kong. We have a voluntary scheme on advanced and specialized nursing practice, which I'll show you. And you can visit our website and you can see some of the details there. It's still a journey. Ideally, if the APN position can be recognized through regulation, that means they will be given a license. That would be even better. But at the moment, it's a beginning stage where we're just establishing a voluntary scheme. But having said that, this voluntary scheme is very important because we start recognizing the value of APN, and also we would have some expectations on their experience, education, to be able to receive this recognition. And some resources that would be of interest to you. If you visit the website, we have put up the competencies of the APN on there, and with the 16 specialties that have been developed with their own core competencies. And in each competence, we have a framework, 5 of the competence area. And if you visit the website and open the PDF file, you can see under each competence is very comprehensive with ability, knowledge, skills, and attitude, clearly stated what would be expected for an advanced practice nurse in that particular specialty area, what needs to be achieved in terms of ability, knowledge, skills, and attitude. Now, my concluding slide here. When we keep expanding our practice, which is needed because our healthcare services are changing every day. So one would ask, are we trespassing to go beyond our boundaries? as long as we practice within the scope of nursing, I think we do not have choice, but we need to go beyond because the demands are there. But the issue is with AI, it actually more than just what I show you, changing the boundaries. Because I would like to share this article with you, which I think is very well said. Previously, we are probably looking at our role boundaries, particularly among different professions. But with AI, actually the professional boundaries are dissolving. For example, the AI system can detect diseases from medical images, even with greater accuracy than human specialists. Routine tasks, if we think we are very busy with routine tasks, and the robots say, I don't need to rest, I can do the task for you. So almost 30%, if not more, nursing tasks can be taken up by robots. So the challenge is how to redefine our expertise. So in this particular article, I think it says expertise for healthcare providers is no longer about knowing the most. It's about interpreting, guiding, and building trust in collaboration with patients and AI, and not forgetting what I have just talked to you about, the work we have done in terms of building the health service model, redesigning the services, and using our expertise, but having that together with our technology and also our higher skill in interpretation, analytics, I think that would even bring our profession go a little bit further in supporting our patients. So find your area, claim your land, and be different, and that will be your brand. I know you have, I understand we have quite a varied variety of group from different countries, different places. You are from different specialties, and I'm sure you can find your own specialties and make yourself different and build your brand. So I'll finish my talk today, and I welcome comments and questions. Thank you very much.